Good morning, everyone. How are you doing today? It is my pleasure to welcome you to our webinar Wednesdays. I am Audra Mitchell, your hostess, and as usual, I'm excited to have you join us today as we explore the topic, diabetes and you. So let me ask you, do you know your numbers? Have you been tested? Do you know that diabetes is a major cause of blindness, kidney failure, heart attacks, stroke, and lower limb amputation? November 14th is World Diabetes Day. And according to the World Health Organization, and I'm reading here, about 422 million people worldwide have diabetes, and 1.6 million deaths are directly attributed to diabetes each year. Sadly, both the number of cases and the prevalence of diabetes have been steadily increasing over the past few decades. Additionally, just under 40% of American COVID-19 deaths have happened to persons who had diabetes, according to the CDC. So, to help us better understand diabetes and its impact, not only on those diagnosed, but their families as well, is our guest presenter, Dr. Nicola Alcala. Allow me to share with you a bit about Dr. Alcala. Dr. Alcala is a general practitioner and diabetologist. So in other words, she specializes in diabetes. She's a graduate of the University of the West Indies Mona and Cave Hill campuses, where she studied medicine and chemistry, and she's also a graduate of Cardiff University in Wales. She previously worked in gerontology in the St. James Medical Complex in Trinidad and Tobago, and in early phase clinical drug development in the UK. On returning to Trinidad, she implemented a public diabetic clinic, which was clinical training for 3 nurses to become diabetic educators. And I don't know if you know, but this year the focus on diabetes is around nurses and their role in helping with educating, as the first person sometimes people see with regards to their diabetic cases. So according to Dr. Alcala, her passion for caring for the diabetic comes from the often needless poor outcomes noted in Trinidad and regionally. She believes that diabetes needs extra support because the disease is not always treated with the seriousness it deserves. And as we've said earlier, the consequences are devastating. Dr. Alcala, has tried to practice yoga for a number of years, and she's also a yoga instructor. So let me now place you in the capable hands of Dr. Alcala. Dr. Alcala, I want to welcome you and thank you for agreeing to share with us today on this topic. Dr. Alcala.
Hello, good morning, everyone. Thank you, Audra, and I have to say thank you to Massy for inviting me here today and for acknowledging diabetes and the fact that actually November is Diabetes Month. So there are a number of activities happening worldwide. And as Audra mentioned, November 14th is World Diabetes Day. So our topic today will be diabetes and you. So this topic may be a little misleading because in this presentation, I'm not just talking to the diabetic. So the and you is, yes, you the diabetic, but you, everyone who has contact with a diabetic, whether it's a co-worker, a family member, a friend, and what is your response to that person? So next slide. So what is diabetes? Diabetes is a disease characterized by high levels of blood sugar, otherwise called glucose. Next. So glucose is the main source of energy used by the body. And it is a very tightly regulated substance in the body because high levels are toxic to many types of cells. So on one hand, your body needs glucose. Approximately 50% of the glucose is used by your brain, 25% by the liver and intestines, and 25% by the muscle. But too much sugar is a poison to many of these cells. So the food that we eat is turned into glucose. Glucose is then taken into the bloodstream, and from the bloodstream, it's distributed to all cells in the body. In order for this to occur, we require a substance called insulin. Next. So what is insulin? You know, everybody talks about insulin. Insulin is a hormone, actually, that it's made by cells in an organ located in the abdomen called the pancreas. So essentially, the pancreas, which is an organ situated behind your liver on the right side of your upper abdomen, or let's say your tummy, right side, that side is where your liver is, and underneath the liver is a small organ that is called the pancreas. And the pancreas makes all the insulin required by the body. So this is just an illustration so that you have an idea of where the pancreas is located. So in order for any glucose to be used by your body, you require insulin. Anything that you eat, apart from water, requires insulin to absorb that glucose into your body and for you to get the energy required for your body to function. Next. So diabetes occurs when your body cannot make sufficient insulin, because if you do not have sufficient insulin, then glucose can't be used. And what happens is that high levels of glucose remain in the bloodstream instead of being distributed around your body. So it can occur when there's not sufficient insulin being made. It can also occur when the insulin is being made, but your body cannot use the insulin. So what happens in that case is that your body becomes blind to insulin. Next. So there are three main types of diabetes: types 1, 2, and gestational. We won't really go into gestational today. Gestational means the diabetes that occurs in pregnancy. But I will say something about gestational diabetes, because gestational diabetes usually means that post-pregnancy, women need to continue to monitor themselves, because usually within 5 to 10 years, many women who have had diabetes in pregnancy become diabetic. So gestational diabetes is a strong risk factor for diabetes, and gestational diabetes can also affect your baby. This is where we have large babies, we have difficult births, and there are medical issues that can occur with a baby born to a diabetic mother. So the main types of diabetes that we are concerned with would be type 1 diabetes and type 2 diabetes. Type 1 diabetes occurs usually when your immune system, for a variety of reasons, attacks your pancreas as if it is a foreign body, so that the pancreas stops working. So in this situation, there's insufficient insulin. But only about 5 to 10% of the population of diabetics have this type of diabetes. You tend to see it in children and adolescents, but more and more we are seeing it in young adults and even in older adults. and you're on insulin for life because, of course, your pancreas isn't making insulin. Now, 90 to 95% of people who are diabetic have type 2 diabetes. And this is largely fueled by obesity, which we are seeing happen more in children because we have a problem with obesity globally. In type 2 diabetes, we tend to use oral therapy and or insulin over time when we're looking at medication. So this is fueled by obesity, and it is obesity that makes your body blind to insulin. So what happens is that your body is making insulin, but your brain doesn't see that there's insulin. So the brain keeps telling your body, make more insulin, I'm not seeing insulin, and the insulin can't work, so that you end up with a vicious cycle of high levels of insulin, high levels of blood sugar. Next. So there are a number of risk factors relating to diabetes, and I have categorized them as changeable and unchangeable. Let's do the unchangeable first, because there are some unchangeable risk factors. The older you get, the more likely you are to become a diabetic. And this ties into genetics and family history, because whether or not you have a family history, age removes that risk factor of family history. Strong family history, you have a stronger possibility of becoming diabetic. But as I tell all my diabetics, a strong family history, it doesn't mean it's inevitable. You don't have to get diabetes with a strong family. This is type 2. With a strong family history, if you do what is necessary to maintain good health. Now, sometimes inevitably with age and the family history, you become a diabetic. But the longer diabetes is delayed, the better. So as I mentioned, previous gestational diabetes and certain ethnicities are more prone to diabetes. So for us, the East Indian and African populations are very susceptible to diabetes, and that is for a variety of reasons. Genetic and diet related. And the changeable would be, what can we do to mitigate the factors of obesity? Diet, exercise are the changeable risk factors. As I said, obesity is a driving force behind your body becoming what we call insulin intolerant, insulin resistant. So that managing obesity by watching diet and exercise totally changes your body metabolism and decreases your risk of becoming a diabetic. There are other factors that people aren't aware of. Depression is a factor for becoming diabetic, and we'll discuss a little bit more of that. Insomnia is also a trigger for diabetes, and stress. I have had patients where stress has brought on diabetes. I had one patient who was 80, absolutely fine, and he had been married for 60 years. His wife died, and within 6 months he was diabetic. And he was very depressed, very stressed, and very sad. And that in that particular situation, we believe that intense stress triggered his diabetes. Next. So what are the signs and symptoms? Very important to pay attention to. Increased thirst, frequent urination, extreme hunger, unexplained weight loss. Now, the patients that present to me quite often present with unexplained weight loss. So, recently I had a 19-year-old who lost 30 pounds within 3 to 4 months. And of course, the family was frantic. And when the mother took him to another doctor, and when the doctor checked his blood sugar was over 500. And I eventually saw that patient and took over the care. So that unexplained weight loss is a big issue. And we have cultural issues as well in the Caribbean, because I have had patients come in to me panicking. thinking that they are HIV positive because they've lost weight, and it's actually diabetes. So, you know, you always have to check whenever you see that sudden, especially sudden unexplained weight loss, and the complaint of being persistently thirsty. Thirst I find more than hunger, and going to the bathroom a lot. Blurred vision, slow healing of sores, and particularly important for women, I have had female diabetics present just having repeated yeast infections, or yeast infections that you keep treating over the counter and it's not going, and they keep getting infections and they're diabetic. Next. So what are the complications of diabetes? As I mentioned, hypoglycemia or high blood glucose levels, both acute, meaning happening right away. You know, you eat that big meal of burger and fries and a Coke, that would cause acute high blood sugar, and then chronic, where you're not following a diet, you're not exercise, so your sugars are regularly running at a high level, even if it is slightly higher than how your body should, your body regulation should be. And once you have high blood glucose, it is toxic to specific cells. So the cells of your blood vessels, your eyes, kidneys, and nerves, the peripheral nerves, meaning the nerves going to your hands and feet, those cells cannot regulate glucose as well as some of the other cells. So that when these cells are insulted with high blood sugars, they can't control the glucose properly and they are damaged or destroyed. Diabetes in particular ravages the blood vessels. That is why diabetes affects every single organ, because your blood supply, your blood vessels are affected. Next. So I call diabetes my head to toe disease because literally every part of the body is affected, from the brain to your feet. So we start with stroke, brain, blindness, loss of sight. Gum disease is something that people aren't aware of or don't pay attention to. Again, I've had diabetics who have lost all their teeth. Now I see extreme diabetics, yeah. So don't be alarmed. You're not, you know, if you're diabetic, you're not going to lose all your teeth right away. If you know, but even when you are, you think, you know, well, you know, I'm slightly diabetic, etc. You end up having a lot of gum disease, and you may notice that you do have more dental issues, and you may not consider or think that it's related to your diabetes. Heart disease. Diabetics have what we call silent heart attacks. So for the diabetic, many times a diabetic will have a sudden heart attack and be shocked. Or we may have an incident in you know, at work where somebody collapses and you find that they've had a heart attack and people are surprised. But when we then test, we see that this person has had heart attacks before. And you don't know, because diabetics don't feel and get the same sensations as other people with heart attacks. And sometimes doctors miss it. You can easily miss it because, again, you're not presenting in a typical way. So kidney failure. In Trinidad, diabetes and hypertension are accounting for the high rates of kidney failure, not just in Trinidad, across the Caribbean and Central and Latin America. Kidney failure related to diabetes, acid reflux, erectile dysfunction, so sexual activity, particularly for men, the loss of sensation in hands and feet, leading to amputations, poor wound healing, poor circulation, nerve damage, leading to amputations. You're more susceptible to infections because diabetes suppresses and affects your immune system, making your white cells sticky so that they can't respond to infection in the way that they should. So you're more at risk for pneumonia, and again, sometimes pneumonia when you don't know you have it, and tuberculosis is also something that flares in diabetics. There's also a possible link to an increase in certain types of cancers. Also, when diabetics have cancers, if they're uncontrolled, they're more difficult to treat. So next. So right now we consider, I mean, we talk about the corona pandemic, but we consider that there's a diabetic pandemic, not just epidemic, because these figures from 2019, 1 in 11 adults globally were already diabetic, and 1 in 13 were pre-diabetic, meaning that they were already impaired. 1 in 6 pregnancies were complicated by diabetes, and 1 in 2 diabetics were undiagnosed. It is estimated by 2035, 1 in 10 diabetic people will be diabetic. So that, think about that. That means that for every 10 people in a room, 1 person is a diabetic. Next. So I just wanted people to have an idea of the prevalence through our Caribbean areas. So these are a few of the countries in the Caribbean that I found prevalence for. Trinidad and Tobago, 12%, this is adult data, 12% of adults. Grenada, 9%. Jamaica, almost 12%. Barbados, almost 18% of the population. Now, I'll make a statement for Trinidad and Tobago. These figures at 13%, have been compiled by the International Diabetes Federation, where you can go and get a lot of information. But we, in Trinidad as medics, we believe that our figures are closer to 18% diabetics. St. Lucia, 12%, Cayman Islands at 14%, Guyana, 10%, Cuba, 13%. And Haiti at 5.7, with a qualification that many Haitians may not be being picked up because of the health situation and access in Haiti. So this is a large burden, because when you're looking at countries like Barbados, I mean, 16%, that is already 1 in 6 people. Think about that, 1 in 6 people already diabetic or pre-diabetic. Next. Now, this information here is from a study done in Trinidad and Tobago a few years ago, about 5 years ago, where it was found that half of the population of 15 years and over were already overweight or obese. A quarter of children, 5 to 18, were overweight and obese. And the recent research was suggesting that by age 12, up to a third of our children will be considered obese. Using body mass index, which is really increasing our risk for type 2 diabetes on top of the type 1 diabetes, which is, a bit special. There's a genetic component with type 1 diabetes, but it isn't very much driven by genetics alone. So type 2 diabetes is our real concern. Next. So management. In the management of diabetes, I always tell my patients the greatest fight is going to be with yourself. Diabetes is fought by understanding the disease and changing your lifestyle. It is a lifestyle illness. And it might sound simple that diabetes is fought by understanding the disease, but I am constantly amazed that my patients coming in, people who have been diabetic 10, 15, 20 years, and simple, what I would have thought simple, or what I would expect you to know after 15 years of being a diabetic, patients actually don't know. I mean, I have had patients 10 years diabetic and they don't check their sugars. They haven't had a glucometer, which is a machine to check your sugar for, doc, it broke a couple of years ago and they never bothered, and at that point, you're going into kidney failure. The other thing is that diabetes is silent and it is relentless. Very important, silent. Again, a lot of people come in, yeah, doc, I know when my sugar is high. You know when your sugar is so high that you are feeling it being high. So when your sugar is 350, you feel it being high. But high for me is 120. So the damage that is being done at 300, where you feel normal for some people feel absolutely fine at 300, 350. And some will say they feel it, but you only feel it when it's that high, and it is relentless. As I said at the beginning, every time your sugar is above the values it should be, every time for an extended period of time, it does damage to the organs. Now let me clarify that, because every time you eat, your sugar goes up. Every time you eat your sugar, it doesn't matter what you eat, your sugar will go up. But the difference between a diabetic and a non-diabetic is that within an hour to 2 hours, usually 2 hours of eating, your sugar levels come right back down to normal, and they stay at a nice baseline normal. The diabetic does not respond like that. The diabetic sugars stay up so that you live in an environment of high sugar. And that can become so bad that it becomes difficult for me to then treat patients, because when I try to get the blood sugar down, the brain and body fight me and fight the person. And you can only get people's sugars then down to a level that would be considered higher than what we would want. Next. So, as I said, management is a change of lifestyle, and that is the hardest thing for us, for all of us. Diet, exercise, medication. I put medication in brackets because people ask, well, how is medication lifestyle change? It is a lifestyle change, because for those who need to be on insulin, that is a completely different change of life. And to accept that that is what you need to do, and to do it, and sometimes get over fear of needles, even testing for people, just testing people who have needle phobias. It's a real problem. I have people who are diabetic with needle phobias, and we have to disguise the needles in order for them to test, so that some types of medication will require a whole change in lifestyle, a whole change in mindset. Next. Now, what is very important for me is that it is very easy for us to say, oh yes, diabetes, exercise, and medication, go forth and change your diet, exercise, and take your medication. But it very rarely works out like that. Diabetes, just like other chronic illnesses, increases your risk of developing depression, and depression increases the risk of developing diabetes. It's what we call a bidirectional sort of interaction. But there's more and more data coming out, which has been, over the past decade, that is actually showing us that persistently high blood glucose levels, combined sometimes with the severe low blood glucose levels that can happen, actually changes the function, chemistry, and structure of certain parts of your brain, which then lead to the development of depression. Because depression, clinical depression, is a chemical issue. Now, there's that aspect, but there's also the life issue of I am a diabetic, so I'm depressed. But that change of brain structure, your brain will fight you to remain in an environment of high sugar, because that's what it loves. So that when you now decide that I am going to bring my blood sugar down, that is not as easy as you think. And for many times diabetic get a lot of negativity from family and co-workers. Don't eat this, don't eat that. But I told you not to do that. And not understanding that there's food addiction, and that the brain is actually being affected. So that, we have to be a little bit gentle and firm. Diabetes also affects memory, again, because of parts of the brain that changes, cognition, and contributes to the acceleration of dementia. And in particular, the studies are showing an increase in Alzheimer's, where Alzheimer's is now being looked at called type 3 diabetes, is our little nickname for it. So that is very important to have control of your blood sugars. And as the you that is not the diabetic, you now have to be able to support, be an ally, be an advocate, as far as you can for the diabetics around you. Next slide. So what are the steps to depression? What happens in a diabetic? What happens is many times when I deliver a diagnosis, people are surprised, they're non-accepting, they become fearful because they've seen their parent lose a leg, end up on dialysis. Many get overwhelmed and feel hopeless. They give up, they don't know what to eat, they develop poor eating habits when they then give up and feel overwhelmed. The lifestyle becomes disordered, they stop taking medication, they don't test, then they start feeling bad about themselves because they think, well, I can't manage this and I can't handle my diet. I am an addict to sugar, nothing that I do. I mean, I hear it constantly, so that they talk themselves into depression sometimes, and that feeling bad about yourself is part of it. But we also have to understand that that high blood sugar also can alter the brain function. And that craving that people have for sugar or have for the food that makes them feel good is a very powerful force. So what happens is that a vicious cycle is developed. So that if you see a colleague, a family member sinking into this type of depression or this type of behavior, where you see your colleague who is a diabetic eating whatever they want all the time, you know, and you don't do it in public, but you take them aside and you ask, well, you know, what's happening? You know, are you all right? What's your numbers? Some people might be hostile to you, but if you show that you care, people often will respond. Next slide. So now speaking directly to the diabetic, because yes, you know, you will have support around you, but sometimes the diabetic does not have support around them. But bearing all that in mind, the reality is that the responsibility for understanding and learning about the disease is on you. In the case of young people and kids at home, the family needs to be involved. But the adult diabetic, too often I see people use our wonderful internet for TikTok as opposed to what is happening with the latest in diabetes. How do I eat? What is the current research? In other words, we have the greatest gift, and it's not of the internet, where we have knowledge at the tip of our, you know, at our fingertips. And sometimes, you know, I don't understand sometimes why, you know, there is not that responsibility to do as much research as possible and then come with it to discuss with me. It's important for you to be consistent and set up a structure. Self-testing is important. Exercise is important. I have had diabetics who have never been to a dietitian. So, you know, they think they know what to eat, but many times, you know, I have to be sometimes very blunt and say, no, you're actually making errors. You're not eating this food at the right time, in the right amounts. People take a lot of advice from people around them, people who are not diabetic. Sometimes, you know, they're getting their advice from. A lot of people want to fix diabetes quickly. That's not going to happen. People want to, you know, a variety of things, drink this tea, eat this food, and my diabetes will be cured, etc. But I'll tell you that I have a handful of diabetics who have been able to manage their diabetes on exercise and diet alone for life. It is rare. And one of the questions always asked is, Doc, is there a cure? And there's a lot of stuff on the internet touting cures. Again, you go into remission with diabetes. For example, I've had patients who've had surgery, bariatric surgery, where they have lost 100 pounds because we do the stomach, what we call stomach stapling. You lose 100 pounds, come off medication, everything is great. And I have one right now, put back on 20 pounds and is back on medication. Because once your body has had that feel of that high blood sugar and your metabolism changes, you develop what we call metabolic memory. So that the minute you put back on weight, the minute you change your lifestyle, the blood sugars are back. So you go into remission, you don't go into cure per se. There needs to be a level of acceptance. You need to ask for help when you need help. It's very important to have a friend, have somebody at work, have an ally, especially where the family is non-supportive or there is no family. I have a 37-year-old who came to see me about a month ago in heart failure and kidney failure. And anytime, I hadn't seen her about a year, and she hadn't been taking care of herself, she stopped. But anytime she came in the past, she came with a friend, a very supportive friend, because the family just was non-supportive. So the responsibility is for your care, shows that you care for your family and removes the burden from the family. Now, a lot of times we don't think along those lines. And I'll give an example. For example, with a lot of men in particular, sorry men, but I have to bring this up because, I often hear, look, doc, I'm going to live my life, This is after I told a patient, look, your kidneys are not looking so good. I'm going to live my life. I saw my mother, going to renal failure. I'm living my life. And he has erectile dysfunction. And I had to point out to him, I said, but is your wife living her life? And when you go into kidney failure, she then has to give her life up to look after you in your mid-40s. And there are a number of men who have erectile dysfunction as a result of diabetes early as in their 40s, and older men. And when I ask them, well, how does your wife feel? Oh, well, it's not a thought really that, it's not a thought that they have a deep, really considering how this is affecting their wife. They say, oh, well, we talk about it, etc. But what you are telling me is that for the next possible 20 years of your wife's life, she, has no other part of her life in the marriage. And many times, just yesterday I had to deal with that. And sometimes I have to be a little harsh because, should you lose a leg, then the family loses income. The state has to pay welfare. And there has to be a certain amount of understanding that your behavior impacts your family. And many people don't like to hear it, but it has to be said. And I have seen people abandon their family members. I had a patient who lost both of his legs by the time he was 50, within 10 years of diagnosis of diabetes. He smoked 3 packs of cigarettes a day, refused to stop, and who then had to look after him by 50 with no legs. So this is also, next slide, last slide for me. This ties into, might be a strange last slide, but this ties in because we have to be mindful. In 2016, the direct total cost of spending on diabetes in Trinidad was 3.5 billion TT. The direct cost, which is medication and paying doctors and nurses, etc., the public service to look after diabetic was $1.2 billion. The indirect cost, which we don't consider, would be the breadwinner who loses a leg. Mommy is at home with 3-4 children. There's now minimal income. The state then pays for those children until they are 18 or more in order to live. And how many, I've had mothers die in their 40s and early 50s within the past couple of years, leaving their children behind. All of those are the indirect costs, and how those families are affected, and in some cases, how those families are destroyed and sometimes disintegrate because the partner left can't look after the families. I think I went over my time. Thank you very much for listening and for everybody who has logged in, and I will answer any questions.
Great. Thank you so much. Wow. I have to tell you, Dr. Alcala, I was taking so many notes and this is really an eye-opening topic. So I know we have persons with some questions. So I'm going to hand you over now to Rennie Barnett, who will take us through the Q&A segment. Rennie?
Hello, good morning. Thank you, Audra. Thank you, Dr. Alcala. Okay, so our first question this morning. I was diagnosed with type 2 diabetes, and I find I'm very fatigued with the medication. If I don't take the meds, I feel no fatigue. I am on metformin and glycoside tablets. What causes this?
Okay, actually, yes, some medication can cause fatigue. And if you are getting fatigue on the medication, well, first of all, we need to make sure that the medication is working. So are your sugars controlled on the medication? Because remember, high blood sugars on their own cause fatigue. So you need to make sure that that medication is effective. But if you continue to feel fatigue, you may need to have your medication changed. There are quite a varied number of medications now, and some newer ones. The newer ones, all the medication works in different ways. The metformin, which is one of the commonest medications and one of the most useful, works to reduce insulin resistance. That's how that works. So that whatever insulin your body is still making, your body is able to utilize it well. That's how metformin works. And the other one, I think you said glycoside, is what we call a sulfonylurea. That's the type of medication it is. Now, how that works is that it forces your pancreas to make insulin. Over time, the sulfonylureas, depending on which one it is, sometimes has to be changed so that because after a while, sometimes your pancreas just cannot do it anymore. And you can get fatigue with the medication. So in that case, you need to talk to your doctor to see if you can change the medication and which one would be suitable for you.
Okay, thank you. Our next question, what are the accepted levels of H1AC?
The HbA1c, yeah. So the HbA1c is what we call glycosylated hemoglobin, all big term for how much of your blood has sugar attached to it, stuck onto it. So the question is not as straightforward as you may think, because the HbA1c varies with age and also varies with chronic illnesses. So a 40-year-old diabetic HbA1c will be different to a 70-year-old diabetic with high blood pressure and who's had a heart attack. So it's difficult to just give an answer, but I will give I will say that for the relatively young diabetic, diabetes alone, more or less, between 6.5 to 7 would be where we would want you to be. I tend to be fairly strict in my young diabetics. I want you at that kind of 6.5, 6.4. Going below 6 for older diabetics can start causing hypoglycemia, meaning low blood sugar. So we don't want to go below 6. And studies have shown that below 6 can actually be detrimental for some older diabetics. For, as I said, people who have diabetes with high blood pressure and are older, we give up to 8 in some cases. So that would be the answer. If you are a young diabetic in your 40s and 50s, I want you at 6.5, between 6, 6.5. That'll be great for control.
Okay, thank you for that answer. Astor is asking, what constitutes a balanced diet?
Yes, now that is a interesting question. Okay. Now this is why I send all my diabetics to a dietitian. I start the diet education with them, but send all of them. Now, I'm not sure if balanced diet, if she's asking with regard to being a non-diabetic and wanting to be on a balanced diet, or being a diabetic, and what does that mean? What does that look like? But I think for all a good, I think a good view for both would be the diet plate, what a plate looks like. Unfortunately, I don't have a picture, but essentially how we should be eating would be, I don't know if y'all have ever seen that plate where a quarter of the plate is carbohydrate, a quarter of your plate is protein, and half of the plate is vegetables and salads and that sort of thing. Now, I have to qualify that statement because while there are general rules with regard to what a balanced diet is, essentially a balanced diet is having the right, quantities of protein, carbohydrates, minerals, etc. for your age, for your activities. Not something that we could just talk about, because it varies so much. But the most important thing is portion control and proper percentages of the main food groups. There is no real diabetic diet. It is portion, it is eating the right food in the right amount and at the right time. There's certain things that I am kind of strict about: white flour, white rice, white potato, white sugars. I tell patients keep those at a minimum. However, if you are eating them, you eat them in the right portion and at the right time. So for example, in Trinidad, we eat pilau, which is rice, peas, and meat. In other Caribbean islands, it might be called something else, but it's a cook-up, in other places. How do we eat it? We have a whole plate of pilau, and right in the corner, we have a piece of lettuce, a piece of tomato, and a piece of cucumber. That's our salad. And we eat that. We go, we go out, or we're at home and some leftover pilau, and we eat a plate of pilau with that at night. You can't do that. What you can do is at lunch, half of your plate is pilau, and the other half is vegetables, salad, etc. That is how you eat. That is how you would eat pilau, and you have that at lunchtime. You can't have that at night and then go to sleep. Remember, one of the good rules for a diabetic and a non-diabetic, always think, I am going to eat this food, and what am I going to do next? Sleep. I'm not going to work, I'm not going to exercise, I'm going to sleep. So your body does not require half of what many of us eat at night, because you're not doing anything. So what you do is you end up sleeping in an environment of high sugars throughout the night, and the body can't utilize it. And what I do with my diabetics, I make them do food diaries. So I make them record every single thing that they eat for 2 weeks as they check their sugars. And many of them are very surprised, because some people will eat peas and their sugars go up. I have patients who can't eat any peas at all except chana. Some will eat lentils and their sugars will go up. Some will eat grapes and their sugars will go up. Others could eat a bunch of grapes and their sugars don't go up. So it means that you also have to learn about yourself as to what raises your sugar. And sometimes people are very surprised. That diet is a whole science on its own, so it's very difficult to just answer it. So I hope that, that helps.
Yes, I'm sure it did, so thank you. Our next question: what if you suffer with ulcerative colitis? Should you be concerned about diabetes, Should your diet be changed to prevent this?
Okay, now ulcerative colitis has an autoimmune component, and diabetes also has an autoimmune component. Ulcerative colitis is essentially, as you know, affects the gastrointestinal, your intestines, and you have issues digesting certain foods, etc. So if you're not a diabetic, it's not so much that, oh my God, I have to be concerned because I have this disease and I am at more risk for diabetes. Your risk might be marginally because it's an autoimmune issue. But I think the most important thing would be to manage your diet to start with, as to how it relates to you having ulcerative colitis. And if you have a family history of diabetes, however, and you have ulcerative colitis, that is definitely a discussion to have with your doctor and to see a dietitian. To ensure that, whatever you're eating, your gut can manage, because gut health is a whole topic on its own. And the health of your gut fuels, your generalized body health, and health of the brain.
Okay, thank you. Our next question. How do you know that you are a diabetic or that you are pre-diabetic? I only go to the doctor once a year or once in 18 months unless I am sick.
Okay, so a couple of things to bear in mind. If you have a family history, you should definitely be a little bit more alert. Well, not just a family history. If you also have not just diabetes, high cholesterol, because diabetes is also, again, diabetes is a disease of fat, of the fats, as well as a disease of your blood sugar. So many times, for example, I will have a patient who comes in to do, say, a general annual blood test, and their cholesterol starts to go up. As soon as I realize that they have a family history of diabetes, I start to warn them, because that dyslipidemia or abnormal cholesterol or lipids is one of the earliest signs of insulin resistance, that you're having a risk for insulin resistance. And that is fueled by a number of factors. Diabetes is a very, very complex metabolic disease, and so is high cholesterol, and the two kind of feed into each other. The important thing to remember is that when sugar is detected in your blood or in your urine, this is very important actually. By the time I get sugar in your urine or blood, you have already been pre-diabetic for 3-4 years before, and damage being done. So cholesterol can be the first sign, and that is when you start to do something about it. Depending on your age group, I usually advise people in their 40s, mid-40s, start doing annual blood tests, panel of blood tests, every year to 2 years, but by 50s, annually. And if you have a history of diabetes, you should check annually. And the signs and complications we discussed. So the sudden weight loss tends to be major, but you see increased thirst. And I'm not just talking about, oh, well, I drink a lot of water because it's hot and I'm thirsty. I'm talking about thirst where you drink water and you feel unquenched. It is an urge or craving that I have to drink as much water as possible, because no matter how much I drink, I'm not feeling satisfied. It's that kind of urge. And you feel, when the hunger is part of it, you feel the same. Extreme hunger. And you know when it happens, because there's a total change to how you would normally feel. So those tend to be it. And as I mentioned, for women, if you notice you keep getting yeast infections often, you should have that checked as well.
All right, thank you. Let's just go to the next question. We have quite a few questions. I'm hoping to get in at least 2 more.
Okay. I won't talk as long then.
This next question is from Gail. Do you allow any time for patients to correct their blood sugars via exercise or diet without medication?
Oh, yeah. Yeah. Now, how I manage diabetes, again, as I tell all my patients, diet is the key to managing diabetes. My treatment is diet first, exercise second, medication third. But as I point out, a lot of people, unfortunately, the majority of diabetics do not maintain diet and exercise and end up having to use medication. That, unfortunately, is what most doctors experience. So unfortunately, many end up having to use medication. I try to make people use as minimal as possible, just enough to control. But in order for me to do that, you need to be doing the rest. Because I do get the, yeah, well, I had my 5 doubles or my 10 mangoes. Amazingly, people eat 10 mangoes. I don't know how that's physically possible. And then, you know, take their medication. They say, but I've taken my medication. And I have to point out it doesn't work like that. Because the length of time you're in a high sugar state is where the damage is done. So yes, I do allow a certain period of time, but if the sugars aren't being controlled, I start on the minimal amount and go from there.
Okay, great, thank you. So I'll ask the last question here from Roxine. So she says, thank you for your presentation, Doc. It was quite informative. Is there any indication that the metabolic, naturopathic, or keto diets help with managing or reversing diabetes?
Is there any? Sorry, is it that she's asking about keto diet?
Yeah, keto diets or metabolic diets, if that helps with reversing or managing diabetes.
All right. Well, again, there's a lot of talk about the keto diet, etc. Now, that is unsuitable for type 1 diabetic. Let me just say that right off the bat, the ones who are on insulin because your pancreas is making no insulin. One of the complications of diabetes is the ketoacidotic coma, when ketones develop in the urine and in your blood, and you can go into a coma. Now, the keto diet is about increasing levels of ketones in your diet. Something that as a diabetic you have to really be very cautious about. If you are going that route, it's not something that I advocate just doing on your own, because ketones in your urine is not a good thing for a diabetic. Actually, ketones in your urine, you can end up being hospitalized if a doctor finds ketones in your urine as a diabetic. That has to be done under guidance, a keto diet for a diabetic. I am an advocate of the low carbohydrate diet. You need a form of energy and you need carbohydrates. You can't get away from needing carbohydrates. But a low carb diet with appropriate fats. Try to avoid things that are labeled low fat, and so a lot of things that say low fat have things added to them, and many things have sugar added to them. So reading labels is very important, and you want to have natural fats, because your cells around your body, your nerves, your brain need fats, and fats are fuel, but the fats make ketones as well. So you need to have healthy fat, and it all has to be in proper proportions. So it needs to be done under guidance, is would be my caveat on that. It's not something to just do on your own. And I do advocate that you communicate a lot with a doctor, a dietitian, your educator, your nurse, and get the appropriate information.
Great, great. Thank you so much, Renee, for moderating our Q&A session. And there's so many questions. Dr. Alcala, I feel we're going to need to bring you back because there are a number of questions here. We've also had some requests for your contact numbers, right, to share with our audience, which we will share so that they can contact you and ask their questions and maybe get to meet you, being a specialist in this field.
That's fine, no problem. It was very, very nice being here. And again, I thank Massy for acknowledging Diabetes Month, because it's not paid the attention, and it is, I mean, we are in a global pandemic. The future is going to be really difficult for some countries, and it already is difficult for countries. In some countries, for example, in Trinidad, where we get insulin free. In the US, for example, people have to share their insulin because insulin is expensive. And, it's just going to get worse. And then never forget the cost of the amputations, the kidney, the dialysis, the heart, the heart and having heart surgery and all the things around this disease, which add to the cost. And we have to be responsible. We can't have the attitude or the mindset that, oh, well, the government will pay for that. Dialysis is extremely expensive. Heart surgery is extremely expensive. And what we pay into the health system does not begin to cover the costs of the complications of diabetes. So that's my last word.
Great, thank you so much.
Thank you very much.
So on behalf of the MLI team, again, we want to thank you for joining us today and presenting such an informative discussion around what is really a critical issue affecting not just us, but our future generations if it's not managed. I'd like to thank our technical team, Jamon and Rennie. Without their support, today would never be possible. And certainly hoping that based on everything you've heard, that we know the importance of getting tested and checking all the time to make sure those numbers are in control. So we want to thank you. Please look out for our upcoming programs, our paid webinars. Certainly, I know we'll be asking Dr. Alcala to visit again and share some more with us. So everybody, have a wonderful day. Remember to keep safe, and please keep leveling up with the Massy Learning Institute. And have a wonderful